let's get started. Okay. So everybody, this is an MS Views Now program. This is an event that we began, just a few weeks after COVID began back in 2020. It's amazing that we're in year 3 now, basically, of COVID. And, we're just going to keep on learning every month, every day. We have new things to learn. So tonight's program, we are supported by Genentech and Biogen, and we want to thank them for, supporting our program. Tonight we have a guest. From most people that know, Dr. Ben Thrower is an awesome doctor out of the Shepherd Center in Atlanta. And yes, he's with the Multiple Sclerosis Institute at the Shepherd Center. And there's another name for it, Carlos somebody, but I never remember it, so I'll just have to skip it for right now. You could say it if you want afterwards. Right, and me, my name is Stuart Schlossman. I'm president and founder of MS Views and News. Tonight's topics are shared decision-making, access to MS care, and about COVID. And, for the many that have not been following this series, we began MS Views Now 1 month after the world shut down. All right, so we've been bringing these COVID updates to everybody all along, and it's been an amazing thing. I mean, if you go back into our YouTube channel and look up MS Views Now and go all the way back to the beginning when nobody knew anything, and then just start listening to some of the programs as it goes forward, the evolution of the programs is incredible to listen to. We can make a movie just out of that. All right, you got that, Bill? He's listening in the background. All right, so let's get started. Dr. Thrower, first, can you just give us a quick intro about you so that everybody knows who they're listening to?
Sure. So my name is Ben Thrower. I'm a neurologist. I'm the medical director here at the Andrew C. Carlos MS Institute at Shepherd Center in Atlanta, Georgia. I've been the medical director here for 20 years now. We take care of about 3,000 individuals with MS. So I'm very blessed to be here. Great comprehensive team, PT, OT, you name it, we've got it.
That's awesome. Thank you for that intro. All right. Again, so, we are going to be doing this program. It is not a presentation by Dr. Thrower. He and I are having a conversation, and we want you all to be involved with it as well. So if you have any questions or comments, please use the arrow where the arrow is in the orange or the red box and type in whatever you want to type in there, as long as it pertains to what we're talking about. By the way, everybody, for those, a lot of people do know, I was on a program right after I got COVID. That was fortunately about 3 weeks ago. And yes, I'm still here. Okay. Yep. Sorry to disappoint some of you, but I am still here. But I do have a cough. All right. And it is a COVID cough. And it does come out when I speak too much or I get too loud. So if you see me drinking different beverages, I have lots of different things, and I have lozenges and I have whatever. It is going to happen to me during this program. If it gets too bad, Dr. Thrower will just take over for a few minutes.
Absolutely.
Okay, so thank you. Can you please define what shared decision making actually is? Who's involved with the shared decision making, and who's the primary decision maker?
So shared decision making is a partnership between the healthcare provider and the person with MS and whoever their support partners are. It could be their spouse, their sibling, their adult children. So it's that patient-centered team, and then the healthcare community. It's the opposite of kind of the old-fashioned way of doing medicine, where the doctor was here and the patient was here, and it was, you do this because I went to medical school and I'm going to tell you what to do, and if you don't like it, you can go somewhere else. Now we're on the level playing field. So the idea is, we want to, as medical providers, we know what we would like to happen for a healthcare outcome. So in multiple sclerosis, we would like for the person to have no relapses and no progression of disability and no new MRI lesions. And then the person with MS and their support team know what they want. They have a risk tolerance for medications. They may say, well, I would rather be on this type of medicine versus that type of medicine. So shared decision making is just that. So we come together, try to see where the common ground is at. And the way that I explain it sometimes is I feel like our team is your guidance counselor. So we want you to know everything we know at a level that's appropriate, and then come to a shared decision about what's best for your health care.
Thank you for that. So what happens when, I hear about this all the time. There's a lot of MS patients that go to see their doctor, and They tell their doctor that they don't want to do this medication. They want to try this. They don't feel that they're doing well. The doctor disagrees and says, no, you're stable. Everything is stable. They say, well, doctor, I'm not walking like I used to. And I think I should change medication. And yet the doctor still is adamant and says, I don't agree. What do you recommend to a person that does this? That goes through this.
Yeah, and that's a common scenario, and I think there are two parts to that. So is it possible that a person is on what we think is the best medication that they can be on, their MRI is not changing, they're not having relapses, and they're still getting worse? Their walking is getting worse, their cognition is getting worse. That happens. It happens every day and in every MS center around the country. So there are a lot of medical explanations for why we think that that's going to happen. I think the job of the medical provider is to explain to the individual with MS and their support team, why do we think that you're on the best therapy, and what are the alternatives, and why are we not looking at those alternatives? We may think that you're on the best thing that we've got, and there really isn't anything better out there, but we need to explain that in a way that it makes sense to the individual. At the end of the day, sometimes there are disagreements between the medical provider and the person living with multiple sclerosis. I have people that decide not to go on any treatment at all, and I disagree with that. But at the end of the day, if I've explained to them what I think the risks and benefits of that decision are, and they make a decision that's different from what I would decide, it's their health, it's their body. I can live with that. I think medical providers have to put their egos aside and realize that it's not about us, it's about us. We're providing a service, and granted, it's a very high level professional service, but it's at the end of the day, we want to make sure that we're doing what's best for the person with living with MS.
Sure. So if a person is not seeing an MS neurologist, and specifically, like they're seeing a small town doctor somewhere, and they're just not getting the level of care that they should be getting, like with what you're first describing right here, what do you recommend that for that person to do? Should they just say, screw you, I'm leaving, I got to go find another doctor? Or should they just try to, work outside the group for a little bit and go see a specialist and see what that specialist has to say?
I think every situation is different. And so if you live in that sort of smaller community, if you could get to an MS center at least once a year, just to have, a second opinion, get some thoughts, bounced around, see what else is out there, I think that's very helpful. What, we need to do at the MS centers is I need to get a sense of what are your local resources. Is your local healthcare team willing to partner with us so that we can go to that team locally in a smaller community in a non-threatening way and say, hey, we're not trying to take your patients away from you. We're trying to just be a help. My experience is most of the neurologists, the general neurologists out in the communities are willing to have that partnership, and they like the help as long as we do it in a reassuring way and say, listen, we're not trying to suck the patients away from you.
Right. Thank you. Not to get off track. Well, I have to get off track for a minute. There's 20 new people that came on since I last said what I was saying before. So I just want to let them know. That's Dr. Thrower. I'm Stuart Schlossman. He and I are just having a conversation about a lot of different things to do with shared decision-making, access to care, and COVID. We're saving COVID for last because there's just so much there. All right. So for everybody that just came online, if you have a question, please type it away. If you have a statement, please type it away, all right? We're not going to necessarily get to what you're saying right now. I don't want too many interruptions during our dialogue, but at the same time, I don't want to tell you not to send it. So if you have something to send, please send it, okay? All right. And everybody should know also, we're supported by Biogen and Genentech. Thank you. Okay, I had to include that. All right, so continuing along here, what does shared decision make? This is not a COVID question, but it has to do with COVID. What does shared decision making look like today in light of COVID?
Yeah, so I think COVID has changed the way that we work with the MS community in some ways, and that a lot of stuff has moved to telehealth. That's been I think there's a good and a bad to that. Just thinking about Georgia, where I'm at. If I have someone with secondary progressive MS who's in a power chair who lives in North Georgia, telehealth is a blessing for them because they don't have to get transportation to come here for a visit. They can stay right there in their living room, and we can have that dialogue. So I think it has made sometimes visits easier. It's made so if I want to see someone, I make a medication change, and they say, well, doc, I'd really like to touch bases with you in 2 weeks. That's a lot easier to do with telehealth now. I think some of the challenges of telehealth is there are things that we need to do that involve hands-on. You can't necessarily do everything that a physical therapist needs to do, via video conferencing. So I think it's been a double-sided coin that with both good and bad for shared decision making.
Do you feel that this model has been impacted by the pandemic?
I personally don't feel that it has. I think we've adapted to it fairly well. I think the MS community has adapted to it fairly well. I think in some ways we may have more of an understanding of what's going on in some people's lives. It's interesting for me doing a teleconference and the person is sitting in their bedroom or their living room, and I can see what's going on in their house, and not to pick on people, but there are some hoarders out there, and someone talks about having gait problems and falling. It's like, well, you've got stuff all over the floor there that you're about to trip over. So sometimes getting our occupational therapists or speech language pathologists for cognitive rehab involved and just helping people organize and a little bit so that we put them at lower fall risk. Those have been some of the things that we didn't get before the pandemic when we weren't doing telehealth.
Right. And what do you recommend to a person who feels that their healthcare provider does not embrace this model and they feel they are not heard or as part of their decision making? I know we spoke about this a few minutes ago, but I wanted to bring it up again simply because, again, there's another group of people that just signed in, and this is important. So
if your medical needs are not getting met, I think the obligation for the person with MS and their support team is to speak up and to say something. Again, everyone's situation is different. If you live in a town where there's only one, neurologist and that's it, that's a different discussion than someone who lives in Atlanta Metro, where you've got a lot of different options of different MS. We have 3 MS centers, and then smart people around there. So I think you want to make sure that your needs are getting met. Medicine has become, unfortunately, more of a business. There are practices that are owned by hospitals. Some of those neurologists are not in control of their schedule. Some of them are told you will see a patient in 15 minutes. So, if you think you're in one of those situations, you could do something as simple as saying, you know what, I know you have 15 minutes to see me. From now on, book me for 2 slots. Give yourself time. MS is complicated. There are a lot of moving parts, and so we need the time to work through all of that. So I think the biggest message I would give is speak up for yourself.
We had an MS center out west contact me this week and tell me that they need to find a way to draw in more of their local MS patients that they're not drawing anymore, and because they've gotten a bad rap of not spending enough time with their patients. Yeah. And they wanted to know what MS Views and News can do to help them. I said, well, we could provide programs for you, but I really think that you need to extend your schedule. If that's the problem, it doesn't matter how many programs you do to try to get patients in if you're going to treat them all the same way.
Yeah. I mean, we've always had the model, and I think a lot of MS centers, have this. We have 30 minutes for follow-ups and an hour for new visits. I tried to put a lot of my new visits on Friday afternoon when there's nothing behind that individual. So if we go an hour and a half, 2 hours, it's not any big deal. There's no one behind that.
Sure, thank you. And MS Views and News has this thing, and I'm going to say it because I helped design it, all right? But it's a tool. It's a two-sided piece of paper that we call a tool, that we made it so that way everything that you want to ask about your health with MS is somewhere on that sheet of paper, all right? And if you fill that out properly and you get it to your doctor before you even walk in the room, chances are you'll be able to get everything answered, before you walk out. Is that something that you all believe in or that you push on patients as well?
Absolutely. You guys did a great job with that tool. So I think it's helpful for the individual with MS. I think it's helpful for us we make sure that we get all the questions answered. Other things that I would add is, if you're making a list of what your issues are for your doctor visit, make sure you put the most important stuff at the top. It sounds silly to say that, but people do it all the time. They'll have 10 questions, and the thing they really wanted to talk about, they save for last. So don't do that. Put your most important thing first. Bring a medication list. Again, seems like a simple thing to do. It helps us with medication reconciliation. Sometimes what we have in our electronic medical record isn't really the way you're taking your medicine, so it's helpful for us to get those updated every time you see us. Ask your healthcare team if there are ways of communicating with them outside of just the doctor visit. So, many practices have an electronic medical record, and we have something called MyChart. And MyChart allows patients to basically email us. So you can say, hey, I have a visit with you coming up next week. Here are the things I'd really like to talk about. Just giving you a heads up on that. Maybe there's a study you're interested in. You don't know if we've heard of it or not. So, give us a little heads up so that we know what's going to be important for you for that visit.
Right. Thank you for that. So I'm glad you brought up MyChart. I mean, I started getting doctors that are using that also, and I said, wow, this is incredible. They actually answer things like within 24 hours, and I don't have to deal with their front desk. I don't have to leave a message or be put on hold for a half hour, So it's pretty cool.
Yeah, MyChart's awesome.
Yeah, I would say so. So, all right, next thing. Again, we have another big group of people that came in since, and again, that's Dr. Thrower. I'm Stuart Schlossman. This is not a presentation. We're having a dialogue about many different things. If you missed the beginning, you'll just have to catch it when this program winds up on our YouTube channel, all right? I'm sorry that you came in 15 minutes late, but, that's why we're doing this and why we're recording it. All right, can you share with us what shared decision-making might look like in an office visit with you?
So pretty much what we've described earlier, that guidance counselor model. So if we're talking about a disease modifying therapy, if we're talking about spasticity management, I want to know what's important to the patient. So the good news is almost every MS symptom that's out there, we have a medication that we can throw back at it. The bad news is almost every symptom a person with MS has, we have a medication we can throw at it. We have to be careful on our part that we're not turning people into walking pharmacies. So just because there is a medication doesn't necessarily mean that we need to write a prescription for it. So I need to know what's important to the individual with MS. How much is this affecting your quality of life? What do you want to do about it? I want you to know what all the options are, what the potential side effects of those options are, and then let's come to some sort of shared decision about, which things we're going to go after, which things we're going to maybe put on the back burner and just watch. So it's, with each visit, when we see an individual, we frequently had an MRI. I want that person to know what their MRIs show, what questions do they have, what medication they're on, what's happened since their last visit, and then give me what's going on so that we can come up with a game plan. Every human has a risk tolerance. And so when we're thinking about a disease-modifying therapy, or we're thinking about symptom management, or we're thinking about not starting a medication, I need to know kind of what your risk tolerance is, what makes you tick. There are people who want to be very aggressive with their MS medications. There are people who want to minimize their MS medications. And I need to help design a plan that's going to fit best with what's important to you.
Okay, thank you for that. What will someone need to prepare to take part in the process? I mean, how do you want them to come ready for a visit with you?
Again, that medication list, at least in your head, have worked out what's going on, what's important. I like to get input from family as well. And if they can't be there, we've, unfortunately with COVID, we've had to limit some of the people we can let into our clinic. So we can always FaceTime in the person or the individual, the spouse, the adult child can write us a note with the patient's permission, telling us what their perspective is. humans are very good at denial. And so, sometimes we talk to the person with MS and we see, is everything going great? Yes, everything's wonderful. And the spouse is sitting in the corner and go, no, it's not wonderful. These are the list of things that are going on. So I think, getting that input from your support partners, having your medication list, having your list of questions, just have kind of an idea of what you want to get out of that visit before you walk in the door.
Right. Thank you for that. For those also that came in late, if you hear me start to cough or my voice go gravelly, that's because I had COVID 3 weeks ago. That's right. And that's with wearing a mask all the time. Not saying that the mask is bad. I'm actually in great shape because I was vaccinated, and I truly believe that. All right. If I didn't get vaccinated, I'd probably not be on this program right now. Okay. Because either I'd be very, very ill or I'd be dead. One of the two. Okay. And I seriously believe in that. So, I came across it somehow. And again, fortunately for me, it wasn't that bad. But, make sure you get vaccinated. That's all I will say. All right. Next thing, how has insurance regulations impacted decisions, and what could someone expect when for example, of their medication may not be immediately approved?
Yeah, this drives us crazy. So, and it's a moving target. It seems like every beginning of the new year, insurance carriers throw out new guidelines for what they're going to cover and what they're not going to cover. If people are not familiar with the term step edits, they should be. Step edits are what insurance companies, it's the playbook that they want you to go by with disease-modifying therapies. So your physician may say, I would like for you to start drug A for your MS because I think that's going to be the best option for you. Your insurance company may come back and say, before you can use drug A, you have to try drug B and drug C. And frequently there's no medical rationale for why they're making you jump through those steps. It usually is a financial decision on the part of the insurance carrier, and those things just drive us crazy. There's been a big move in relapsing MS to use more effective therapies earlier on. And sometimes that butts heads with what the insurance company is going to let us do. They're going to want the person to try something else. Symptomatic medications. If I have someone who has urinary urgency and frequency, and I think Myrbetriq might be a great option for them, they're probably not going to let me use Myrbetriq as my first choice. They're going to want you to try Detrol and Ditropan or a couple of those older medications first. So it's frustrating. Sadly, it's the world that we all live in now.
That brings up another thing about this shared decision making. A lot of the older doctors only believe in the older medications. Is there anything to say for that?
So just because there's a balance to that. So sometimes the older medications are perfectly fine, and sometimes there is a tendency on the part of medicine to jump to the newest thing that's out there. Usually the newest thing is also going to be the more expensive thing and the thing that you have to jump through more insurance hoops to get. And sometimes there are older options that may be just as effective. A great example of that's in the hypertension world. The old drug hydrochlorothiazide, one of the cheapest drugs ever made. Is it new? Is it sexy? No, it's old school. It's very boring, but it works for a lot of people and it's dirt cheap. So there's a balance. We want the healthcare provider to be up on the latest things and realize that medicine evolves, and sometimes we need to move on and drop old things, but sometimes we don't want to be the first to jump on the bandwagon. Sometimes the older medications are okay.
Okay, thank you for that. Let me quickly remind everybody, if you're asking questions online that you've already asked when you registered, please don't, because I'm going to forget, and then I'm going to ask it again, and then I'm going to look stupid, and I don't like to look stupid. So please don't ask the same question you asked when you registered. A couple of people have done that. Also, for everybody that came in not in the first 5 minutes of the program, the topics for tonight are shared decision making, is access to care, and it is COVID. And so please do not be asking about why and what causes MS and other things like that, because we just don't have time for it, okay? It has been discussed often in the past. It will be discussed in the future, but it's just not for tonight's program. So please understand that. Okay, next. Going back to step therapy and induction therapy, is there a reason why especially, and again, I said about older doctors going with the older therapies, but a lot of your new doctors just want to get to what they believe is the stop for your MS. But what happens if that drug doesn't work? Now, how do you go back and do anything else?
Yeah, so I mean, you use two terms, a step therapy and induction. So just so folks know, so step therapy is picking a therapy that's modestly effective, great safety profile. If that doesn't work, then we're going to move up the food chain, step up the food chain. Induction therapy, I'm going to use a bigger gun up front, a natalizumab, an ocrelizumab, something like that up front. The reason that most, I think, MS centers have moved towards induction therapy, use the most effective therapy as early as possible, is we know that there's a window of time when the MS fire is easier to put out. And sometimes by the time we know that your step therapy has not worked, so we put you on a less effective therapy, now you have disability that may not be reversible. You've had relapses that have left you with that new level of disability. And with current technology, we don't get a do-over on that disability. I would rather prevent it up front. We've learned a lot about how to use some of these more effective therapies safely. And so if we can manage the risk and put you on something more effective, that would be my preference. This is where that shared decision making comes in. So I give that talk to someone with MS and they say, can you tell me that there's zero risk of PML or progressive multifocal leukoencephalopathy with Tysabri? No, I can't. Well, unless you can tell me there's zero risk, that's not acceptable to me. I have to live with that. That's their decision. That is their risk tolerance. So it might not be the decision I would have made for myself or my family, but it's what's right for them.
Sure, thank you for that. Let's talk a little about access. All right, so the access to the care. What are we doing for children with multiple sclerosis? I mean, what kind of obviously the parents have to be involved with that, and the child, maybe if too young, doesn't have a say in the matter. But what if that person wants to have a say? What if an 8-year-old, 9-year-old, 10-year-old with MS wants to say, hey, daddy, mommy, doctor, whatever, I want to get this thing stopped now. And what if the parents are against it? Then what do you do?
Yeah, that's a tough one. I mean, I think it's different if you have, say, a 16-year-old, that probably has more autonomy in their medical decision making versus, say, an 8-year-old. I think if you have a conflict between what a truly minor child, an 8-year-old, wants and what their parents want, you got to get a counselor, a mediator in there. Depends on who you think is the more reasonable party.
Sure.
But I think getting a mediator in there to do some education and say, I've seen that situation. I had a child years ago that was in an ugly divorce, an ugly custody battle, and the parents bickered. It was the parents that disagreed over the treatment path and didn't let the 13-year-old have any say in the matter. And this child went 2 years without treatment while the parents argued about what was going to be right for that. I mean, it almost got to the point of needing to bring child protective services in because the kid was clearly being was suffering for that.
Yeah. Is there an oral med for the children?
So I know Gilenya has been and I can't remember right offhand if that is FDA approved. We don't. So whether a lot of times in MS, a lot of these drugs were not FDA approved under the age of 18 because they were studied in people between 18 and 55. Traditionally, we didn't necessarily say we're not going to offer a 16-year-old or a 15-year-old a medication just because it's not FDA approved. We would fight for that child to have access to whatever medicine we thought was going to be most effective, whether or not it was FDA approved in that age range. We should mention too that there are pediatric centers of excellence. So years ago, the National MS Society realized that we weren't doing a great job with pediatric MS and established a pediatric center of excellence for each corner of the country. For us here in the Southeast, our center of excellence is University of Alabama, Birmingham for pediatric care. So every adult MS center has a certain comfort level. So for us, we're comfortable with 12 and up. If we have someone under that age, we're going to definitely get them over to University of Alabama, Birmingham to get at least a one-time opinion, if not get all of their care there.
Right. Can you tell us where the other centers are? I mean, I know there's one in Stony Brook, but I'll leave that up to you.
Yes, so Stony Brook, I think, so it's University of Washington is the Center for the Northwest, and I don't remember right offhand in California what they're. It's one of the university-based University of California centers for the southwestern corner of the country.
Okay, great, thank you. For everybody that's typing in questions, please know that I will get to them later on. All right, I'm not going to stop and look at the questions now, but I will get to them later on. And even if they duplicate something that we've already discussed, it's okay, because probably everybody will forget anyway. Okay. All right, let's go on to a little bit something different on this topic, and then we'll slide into COVID in a few moments. All right. How has the pandemic impacted MS patients on Medicare and Medicaid?
I don't know that it has necessarily impacted them differently than other insurance carriers. I would say if you're a Medicare recipient, I mean, you're more likely to either be above the age of 65, or you are on Medicare for disability reasons. So you have the mobility issues. If you're seeing a practice that doesn't have telehealth capability, I mean, you can definitely, then your options for treatment may have gotten limited. We have heard of practices shutting down completely due to either their staff being ill or COVID fears, and limiting access to care for some individuals. Medicaid, folks are typically at a lower income level, so sometimes their transportation issues have been compromised. I know here in Atlanta, for instance, we've at times had MARTA, our mobility and public transportation has had limited runs, so sometimes that transportation issue has been an issue for Medicaid recipients.
Yeah. We've actually heard that there are doctors here in Florida, I don't know about outside, but they're not taking new patients that have Medicare.
That happens. I mean, that's been going on forever across the country, and a lot of practices will limit the number of Medicare patients, right, or they don't accept it at all. And so right. I send a lot of, so if I have an individual with Medicare or Medicaid who's looking for, say, a new primary care doctor, I frequently refer them to vitals.com. It's a website. It's kind of like Angie's List for healthcare providers. So you can go on vitals.com, punch in whatever specialty you're looking for, urology, primary care, put in your zip code and how far you're willing to go. So maybe you're looking at a 15-mile radius, and it'll pull up providers and it'll tell you what insurances they will work with. We use our case managers a lot. We refer a lot of folks out to the Georgia chapter of the National MS Society for help with referrals as well. So people just need to know what their resources are.
That's good. That's good. Thank you for that. Are all services and accessibility available at doctors' offices and hospitals across the country? I am asking this because I was in New York back in November, and I find that the city that never sleeps has the worst accessibility for patients with scooters, walkers, that, of anything that's going on with them, but there's no curb cuts in most places. And so I wanted to ask that question to you about doctors' offices and hospitals.
Yeah, I think you just answered it. I mean, clearly there's a wide range of accessibility out there. Some of the challenges that we see people with MS facing are things like women and their GYN appointments. So, not being able to, so there's not an accessible table. So someone in a power chair, can't get a pelvic exam because there's not an accessible table, or dentist offices that are not handicapped accessible. That's where, again, if you're working with an MS center, your case managers probably have a list of accessible offices for different specialties, whether it's primary care or a dentist's office. Your Georgia chapter of the National MS Society should have a referral list of accessible offices. I would refer people to either case managers or your local chapter of the National MS Society for help with that.
Okay, thank you for that. And another thing to do with access, airports, on major depots, whatnot, are horrendous places for a person that's needing an accessible toilet to get an accessible toilet, because there aren't signs on all the doors that say for physically needed people only, not just a sign of it, a handicap sign. But how do you keep people that don't need a toilet like that out of it.
Yeah, you're talking about curing human rudeness. If you figure that one out, let me know. So if you will, on my Facebook page just this afternoon, I posted a link for a website for traveling with disabilities. So it was Shepherd put that. If you could take a look at that and see if you want to post it on your site. The other thing that people with MS can look at is in working with physical therapists. Some physical therapists, I know ours do this, do field trips for people with mobility issues. So our physical therapist will actually take the person to the airport. So we have individuals who say, I'm going on a cruise, and the thought of going to the airport scares the heck out of me. I don't know how to navigate this. So our physical therapist will actually do a field trip with them to the airport, walk them through all the different steps and show them, okay, let's look at where the challenges are, and let's make sure that you're going to be able to navigate all of these hurdles and just take the anxiety level down a little bit for doing that.
Okay, understandable. Going back to another thing, with access and issues and whatnot, how do you get people to understand more about the invisible symptoms of MS? I mean, sometimes people who don't believe in this, or even family members that don't see their loved one of actually having any issues, they think that, oh, you have MS, you can't walk anymore. But what about just being tired, just being fatigued, just having pain in the body or whatnot?
So I think just constant education for the support partners. Number one, make sure that you validate the person with MS, that they realize that these are real things, that fatigue and cognitive dysfunction and pain are hidden to the general public, but they're very real and they very definitely affect quality of life for people with MS. And now we need to, try to bring those support partners into the loop, whether it's getting them in for in-person visits so we can have that conversation, doing letting them FaceTime in for a visit. There are resources. The National MS Society has a brochure called "But You Look So Good" that talks about some of the invisible symptoms. I know you've done programs, on some of these invisible symptoms. I refer a lot of people to the Can Do MS group.
Right.
They have a lot of resources on the Can Do MS website talking about some of these invisible symptoms. And one of the things I love that Can Do is focusing on is trying to do programs specifically for care partners, getting them into a room where they can get education and where they can talk about some of the things the challenges that they have. MS doesn't affect just the person with MS, it affects that whole family unit. And we need to kind of look at taking care of the whole picture, because if any of that breaks down, it's not going to be beneficial to the person with MS.
Sure, thank you. A couple of people are asking where they get that front and back page or whatever tool to speak to the healthcare provider. And I'm just going to tell you that if you visit the MS Views and News website, one of the drop downs at the top, I don't remember which one it is, but you'll find it says patient communication tool. So that's where it would be. Okay. All right. Done with that. All right. Next, we have COVID question. I mean, we have COVID stuff to talk about, and yeah, this is like endless, right? So I have 3 pages of that. Plus, most of the questions coming in online right now are about COVID. All right, some aren't, but some aren't even having anything to do with our topics. So we're going to skip those altogether. All right. So first thing from your list. You have a big list here too. All right. What is the current state of COVID in America?
Yeah, so right now we are living through the Omicron sort of surge. So COVID is ever changing. We have dealt with the Delta variant surge back in primarily August, September, October. As that quieted down, then in South Africa, we had the Omicron variant pop up. So 99% of what we're seeing with COVID cases right now are the Omicron variant. People may have heard Omicron is magnificently contagious. It is more contagious than Delta by several factors. But the good news is that for most people, Omicron is milder, much milder than Delta. Most people who get Omicron are not going to end up in the hospital. Now, obviously, if you have other health issues, if you're an older individual, young children have had a little higher rate of hospitalization. So we don't want to minimize the seriousness of Omicron, but thank God, it does seem to be less virulent than Delta was by a bit.
Again, I had it almost 3 weeks ago, and for those that didn't hear me talk about it before, I was concerned. I mean, I was really, really concerned. First off, 2 close friends of mine died just within days of when I got infected by this as well, and they died because they had other health, problems going on. They were a husband and wife. They died 3 days apart. Okay, really destroyed me with this happening to them as well. But it made me very concerned as to how I was. I was very congested. All right, and I made sure to sit up every night to go to sleep. I refused to lay down. I didn't want all that crap in my, upper respiratory area even building up. And, again, though I knew I was vaccinated, so I felt that, I have a very good chance of not getting worse. But that doesn't mean that it wasn't going to get worse, hence what happened to my friends. All right, so, it was scary. But, once the 4 or 5 days of, harshness disappeared, then that was great. I mean, I knew that the rest is going to be easy, but it's still here. It's here. You can hear it in my throat. All right. But yeah, that's the current state is that, we're dealing with this Omicron, and I have no idea how I got it, but it is there. All right. Next, are people with MS generally at higher risk for COVID?
So one of the misperceptions that many with MS still hold is that they have a compromised immune system. So MS all by itself does not suppress your immune system. People with multiple sclerosis have a relatively overactive immune system, specifically as it relates to myelin and axon. So you have an immune system that is inappropriately attacking the myelin and the axons. The question then is, okay, when we now start treating your MS, do we change that dynamic? So MS by itself does not put a person at higher risk for getting COVID or for having a bad outcome with COVID in general. We need to think about certain medications, though. So some of our medications could, in theory, change that dynamic. Things like our B-cell therapies, so ocrelizumab, Ocrevus, rituximab, Rituxan, Kesimpta, Truxima, which is basically a biosimilar to Ocrevus, the S1P drugs, so that's going to be your Gilenya, Mayzent, Zeposia, Ponvory type medications, and then Lemtrada. These are medicines that, because of the way they work in the immune system, could compromise the immune system in a way that could put a person at higher risk for getting COVID or getting sicker with COVID. And they also could change the way your body reacts to vaccination. So those medications could potentially lower the antibody response that you get with vaccinations, specifically the B-cell therapies. In our practice, that's been the biggest challenge, or the B-cell therapies, your Ocrevus, Rituxan drugs. We have seen the majority of patients who are vaccinated and boosted on a B-cell therapy are not making a great antibody response. They still make a good T-cell response. There are 2 parts of vaccination. There's the antibodies and there's T-cells. What studies have shown is that even if you're on a B-cell therapy, you're still going to make a good T-cell response. You may not make a lot of antibodies, and we can do a blood test to measure that. So then we start thinking about, how do we protect you further if you are on a B-cell therapy? Do we need to have you be a little more cautious about social distancing, be really cautious about masking? The other strategy that has come up is, if you didn't make antibodies with vaccination, what if we just gave you antibodies passively? If we gave you one of the COVID monoclonal antibodies, so there are 3 of them out there that were authorized. The FDA took one of them back, Regeneron, because they said it wasn't effective for Omicron. So we have Evusheld, which is FDA authorized not only to treat COVID, but also as potential prophylaxis. So for our B-cell therapy patients, we are at least offering them a dose of Evusheld to give them antibodies if they didn't make great antibodies with vaccination. So you're not asking your immune system to make antibodies. We're just passively giving them to you. It's 2 intramuscular shots, 1 at each hip, given at the same time. So you walk out of right after that shot, you have antibodies. We know those antibodies with the Evusheld product are effective against the original COVID. They're effective against the Delta variant. they're kind of effective against Omicron. They weren't designed for Omicron, but it does look, it offers you some protection against Omicron. And those antibodies may last for up to 8 months.
Are you recommending Evusheld for all your patients on any of the B cells depleters?
I think it's a conversation that needs to be had with every MS patient on a B cell therapy. To at least put it out there. Here's the challenge, though. At some of these monoclonal antibodies, it's not like they're sitting on the shelf just waiting for us to grab them.
Right.
We asked for, I believe, Shepardson, we had asked for probably 200 doses. I think we got 100 in, so we're asking for more. We have Regeneron, but then the FDA took that authorization back, which you could argue about the wisdom of that. So we need to not only think about what's going on with COVID right now, but what's going to be happening with COVID in 2 and 3 months. Once Omicron's gone, which it probably will be on a national level within a month or so, if we're lucky, what does COVID look like then? Does Delta rear its head again, or has Omicron wiped Delta off the face of the earth? Hopefully it has. Hopefully it's outcompeted it into extinction.
I think we're going to learn what the next letter in the Greek alphabet is.
We may run out of letters. I hope we don't.
We might. Quick question: you labeled all the drugs that can be affected by COVID. Which are the safer MS medications then that you can list?
Yeah, so your old platform therapies, your interferons, Avonex, Betaseron, Rebif, Extavia, Copaxone, Glatopa, all of those we see zero risk of altering your immune function in a way that would impact COVID in any way. Aubagio, teriflunomide, we're really not seeing any issues with that. Tecfidera and Vumerity and the dimethyl fumarate, the generic for Tecfidera, not really seeing any issues there. So those I don't worry about in the MS community who's on one of those medications in terms of COVID.
Right. What about natalizumab? See, I'm getting there.
Yeah. So natalizumab, I would put in that group as well. We have seen zero issues with Tysabri. Mavenclad, interestingly, even though it has pretty dramatic effects when you take your first doses on B and T cells, really have not seen any effects in terms of higher risk of COVID or bad outcomes with COVID with Mavenclad.
Okay. So, interestingly, when COVID first reared its ugly head in the United States, I said to my doctors, hey, maybe I should come off of my therapy. And they said, why would you want to do that? I said, because I want to raise get my immune system even higher above where it currently is, is too elevated. And they said, well, that sounds great, but I really don't want you to come off your medication. So a lot of people have actually said this to me after that, and I want you to let them know why they shouldn't stop their medication. Yeah.
So there's a balance between, what COVID is doing and what your MS is doing. I think that we can safely keep people on treatments and keep your MS under control. Again, sometimes we're having to think about little minor tweaks, like with an Ocrevus. Do we need to think about changing your dosing schedule, or maybe lowering the dose, or thinking about when we do your vaccinations? But MS is a lifetime problem. You're in it for the long haul, and these treatments are long-term therapies. It's a marathon. COVID, although it feels like we've been living with it forever, the pandemic is going to go away. We may be left with an endemic form, so we're dealing with something like influenza, but I don't like to see people make decisions that are going to affect their long-term health and their long-term ability to function for a short-term issue. That's not to downplay how important COVID has been. I mean, it's been deadly serious, as you mentioned, with the deaths you've seen. But I think we can work around those risks and keep people on their therapy.
Okay, thank you. Are COVID vaccines safe for the MS population?
Absolutely. So early on, before we had any safety data, the National MS Society had convened a panel of experts and looked at the what they thought the long-term safety would be, and they strongly advised using their crystal ball scientifically that they thought that these vaccines were going to be safe. Now we have hard data. There was just a paper published last month that looked at how people with MS were responding to vaccination versus the non-MS community, and they saw no difference. That's not to say that vaccines don't have side effects. Every vaccine known to man has some small risk associated with it, but those small risks do not appear to be any different in the MS community than they are in the non-MS community.
Thank you. What if somebody was vaccinated prior to going on to like an Ocrevus or a Mavenclad or whatever? Do they have to be concerned at all?
So if you're vaccinated before you go on one of those drugs, we don't wipe out that immunity with the drug. So you keep those memory cells, you keep those antibodies. Now, in all of us, that protective effect of the vaccine may lessen over time just as the immune system changes, but it's not the medication changing that protection. So we would prefer, when people are going on one of these more effective therapies that could affect antibody production, we would prefer that they get vaccinated before starting the medication so they've got that protection on board.
Okay. Is there any, when you're saying that though, what happens later on when they go for like a booster?
Yeah, so that's the issue. So now you're on the medication, and so now you're trying to form new memory cells. So that's where the issue comes into play. So you've got the protection from ahead of time. When that goes away, we do have to think about what kind of response are you going to get to vaccination. Again, we know, so we can measure COVID antibodies. We can see if you got a booster response or not. If you didn't, then do we need to think about giving you the antibodies with something like the Evusheld product?
Right. Does Evusheld need to be given more than one time?
We don't know that. So right now, we're thinking, okay, we give you Evusheld, we've bought you, 6 months, 8 months of protection. I would imagine if the pandemic is still raging, hopefully not into the summer, and your antibodies go away, we probably would have to redose with Evusheld again.
Right. Okay, for that. Now, do certain MS therapies change the, I think we just spoke about that. Are COVID therapies safe for people with multiple sclerosis? Did we already do that too?
No, we've not done that one, but good question, and yes, they are. So any of the COVID monoclonal antibodies or the oral antivirals, so like Paxlovid, the Pfizer product, those are absolutely fine for a person with MS to take.
Okay, thank you. Have you seen any cases where MS symptoms worsen after a COVID vaccine and don't get back to their baseline?
So we have definitely seen pseudo exacerbations after vaccination and with COVID infections as well. Both, doesn't matter if you're vaccinated or if you have a COVID infection, your immune system is reacting to that. So with a vaccination, you're trying to kind of fool your immune system into thinking that it's got a little bit of an infection. One of the things that we know that revs up during a viral infection and probably with vaccination is something called gamma interferon. Gamma interferon is a great antiviral. It's probably not your friend in the short run with MS. It's going to make old symptoms act up. So most of what we're seeing after vaccination or after infection is a pseudo exacerbation. It's a driven response. I've not seen anything permanent, but I have seen some symptoms linger for weeks and months after infection or vaccination.
Great, thank you for that. Next, we're going to get into some of the people's questions, although I have intermittently added them in as well. But do monoclonal antibodies have a positive or negative effect against this new variant?
So the best monoclonal antibody against Omicron is sotrovimab. It's also the hardest one to find. We have applied for it here a lot, and a lot of medical facilities have asked for it, and we have not gotten a single dose. And so ideally, I would give sotrovimab. Evusheld does have some effectiveness against Omicron as well. It's not perfect. It wasn't designed for Omicron, but it does give you some protection.
I actually looked for that after I was diagnosed, and I was told that if I find a bunker of them in the United States somewhere, to please let everybody else know.
Yeah, it's frustrating.
I would imagine. All right. Next, let's see. A person is writing two Moderna vaccines and a booster. How safe am I from Omicron?
So you can clearly you can still get Omicron after being fully boosted. The vaccines were designed with the original variants in mind, and Omicron has changed the spike protein pretty significantly. So what we know with vaccination, so you've had your Moderna, your 2 doses plus a booster. You can still get Omicron, but you are a lot less likely to end up in the hospital if you do get it. So you're more likely to have a mild case. So, don't buy into the dogma out there that, well, vaccinations aren't helping me at all. They are still helping. They're decreasing hospitalization rates for vaccination. And again, realize that just because we're living with Omicron right now, what are we going to be living with 2 months from now? What if Delta rears its head or something like Delta pops back up? Praying that it doesn't, but so I think it's still worth doing what you did.
Very true. So for everybody that there are a few people that have asked, am I traveling? The answer is no, I haven't been traveling. But this is my last week at home when I say traveling, yeah, I've been traveling on the ground, but not by air. And next week I feel comfortable enough to travel again. But it won't be in the air yet, but it will be that we're doing a live MS event again. And so we're going to be doing that in Daytona, Florida. For anybody that's on here that lives near there, hey, this is a good plug to say that. And by the way, when am I traveling by air? Well, I'll be traveling at the end of February. We're doing a program in Greenville, South Carolina. So if you don't know about it, now you know about it. You want to know more about it, then just contact me, all right? But we are doing a live event there with Dr. Mary Hughes and a Pilates specialist that works with us right now. She does, one of our programs on one Monday of every month. So, it's a plug for that program. The answer is I feel safe. And according to the CDC, I am safe. All right. And even though I might still be testing positive, it's because there's trace of the virus somewhere still left in my body, but that I shouldn't be stopping that from living my life at this point in time. I no longer have a fever. I survived this. I now have antibodies that most of you don't have. Okay. And I feel that puts me at the top of the food chain in this. All right. So, but listen, it was a risk, and it was unfortunate that I or others are getting this, and unfortunate really for those that have perished from this disease. So, listen to the doctor and listen to what he says about what you can do, what you can't do. And he really hasn't said anything what you can't do, just, what you should learn to do better. Okay. All right. Next question. What side effects have people with MS experienced after having the vaccine? What is like the major side effect that they're having?
Yeah. So think of a pseudo exacerbation. So if you get overheated or you get just a common cold, what symptoms for you individually act up? Maybe for one person, it's their foot drop worsens. Maybe for someone else, it's their vision gets a little dimmer. Someone else is more fatigued. So it's going to be individual. So depending upon where those old areas of demyelination are at in your central nervous system, when your immune system revs up a little bit, those are going to probably be the symptoms that act up for you. So everyone with vaccination has a risk of the usual post-vaccine side effects: low-grade fever, feeling crappy, fatigue, headache, aches and pains. That's across the board, MS or not MS. If you put MS into the mix, then you get a little bit of risk of that pseudo exacerbation, and that's going to be unique to you, depending upon where your areas of demyelination are at.
Right. Thank you for that. So a lot of people are asking me if I got the fatigue from it. And I said, I've had worse fatigue from my MS. So, it's all relative, though. It's all relative. So a person that does not live with fatigue, yeah, knock the crap out of them. But I've had fatigue part of my life for most of my life. So, again, it's how you deal with it, I guess.
Yeah, I mean, it's been all over the map. My wife has a pediatrician. I think we were having this conversation earlier, around the holidays. people traveling. They had kids that needed to get COVID tests for travel. They had no symptoms whatsoever, and a lot of these kids tested positive for COVID, and it was probably Omicron. And then you had kids who were legitimately sick. They came in and looked like they had the flu.
That's right.
So it really is just all over the map. Headaches were a much bigger part of Omicron than they were with Delta. Omicron is a lot more of an upper respiratory thing than a pneumonia thing. So there was less of the loss of sense of taste and smell with Omicron. There was more headache with Omicron. Maybe more GI side effects with Omicron, although that was not quite as clear, but it clearly was different from Delta.
What about people getting a backache from Omicron?
Yeah, they definitely saw that as well. Yeah, absolutely.
All right. We have a person asking, tell us about people on B-cell depleting therapies. Will the vaccine still protect them against Omicron?
So vaccines don't fully protect anyone against Omicron, B cells or not. So they protect you from getting really sick. You can still get Omicron if you've been vaccinated and boosted. So it's important to still don't think you're Superman or Superwoman just because you've been boosted. Omicron is crazy contagious. The B cell therapies then throw one more layer into that. With the B cell therapy, there is a decent chance you didn't make antibodies to vaccination. So you could be at a little more risk for getting Omicron if you're on a B cell therapy. And that's where, again, maybe having that conversation with your healthcare team about getting Evusheld if they have it might be worthwhile.
So going back to the Evusheld for a minute, I have a question. Would that basically be good then for anybody with MS, whether or not you're on a B-cell therapy, as a preventative, as like you said, it's an antibody treatment? So.
Yeah, I mean, in a perfect world, if there were unlimited supplies, you could argue maybe everyone should just do it. It's probably going to be overkill for the person without MS, or even the person with MS who's not on a therapy that can alter antibody production. If you've been boosted, you have antibodies. So getting Evusheld is probably you're just kind of overkilling at that point. You can only make so many antibodies. I think we live in the real world, and so we do have short supplies, so we do have to be thoughtful, about that. I know, there were even discussions when we got it in, we had people, getting Omicron left and right as part of our team, and at one point we were short about 25% of our employees, and so staff was saying, hey, should we just do a dose of Evusheld? Yeah, in a perfect world, if we had enough, we would, but we don't have enough, so no, we're saving it for people on therapies with MS that need it.
Right. Just like at the beginning, save on the toilet paper, right?
Yeah.
You don't have to buy a house full. All right. Next question. Person's writing, if you're on Gilenya and had the J&J, that's Johnson & Johnson vaccine, and one Pfizer booster, do you recommend another booster and perhaps two for a total of three, or a total of three?
Yeah. So if you've had one J&J and one Pfizer or Moderna, I mean, you should be, fully boosted. There was a lot of thought that J&J might not be as effective as Pfizer or Moderna, and some people pushed back on that and said, well, their study was done later in the course of things when there were more variants out there. So the bar may have been higher for efficacy for J&J than it was. So personally, if I'm on Gilenya and I've had J&J and a Pfizer booster, I would probably get blood testing for COVID antibodies and see if you've got enough antibodies. And then if you don't have adequate COVID antibodies, then think about doing another Pfizer booster.
Okay, thank you. Next, by the way, everybody, we're going to be finished by about 8:15, so maybe 8:20, because I have a lot of questions remaining. All right, next one is when people with MS or not get COVID and immediately given the MOAB shot that provides a boost for roughly 3 months, how does that play into the body's natural ability to mount the proper immune response so as to not get the next variant?
Yeah, so we wouldn't think that the monoclonal antibodies would have a kind of a negative feedback loop. It's not like you're telling your immune system, hey, you've done enough here, let's not do anything else. You're still going to make an antibody. If you see something new, let's say that the next variant is completely unresponsive to the monoclonal antibodies you've got, you should still mount a novel immune response with both B cells, antibodies, and T cells. So I don't think you're putting yourself at higher risk by getting antibodies right now. There's not a negative feedback loop to your immune system.
Okay, thank you. 3 different people just asked almost the same exact question about antibody. One writes, can you measure the antibody levels? The next one writes, what is adequate antibodies? And the third one writes, what are adequate COVID antibody numbers on the blood test?
Yeah, so there are different antibody tests. Most MS centers, I would imagine most practices are using the Mayo Clinic assay. And if you look on there, so there's it will say there's a disclaimer that we don't really know exactly what the protective antibody is. But what you're going to see in most people when you get those results back is it's not going to require a lot of sort of detective work. Either the antibodies are going to be negative, you got none, or they're going to be barely detectable, which is probably about the same as being none, or they're going to be really high. So I don't know that we know an absolute cutoff number that says this is the protective number. But for right now, we kind of see those 3 groups: none, very little, and a lot. And so I want the person to be in the a lot group.
Okay, thank you. The next person is asking he says, my doctor is saying a 4th shot booster is necessary. What is your opinion?
And this is my opinion. I'm not there yet. The study out of Israel said that their study was negative on the protective effect of 4th shots, but then they're going ahead and doing it anyway. Now you could say, well, what's the harm? It's one more layer of protection. Realize too, when we're thinking about additional doses versus boosters, those are different things. So if you're considered to be immunocompromised, we could do an additional dose. So let's say you've never been vaccinated. So you could do a dose now of Moderna, another dose, a couple, say 4 weeks later, and then another dose 4 weeks after that. That's not a booster. That's an additional dose because we think you need that much vaccine to mount an initial response. Then when you do another dose 6 months from now, that's your booster. So that person has technically had 4 doses, and I would recommend that because they were immunocompromised up front. If you're talking to someone who's not immunocompromised, they got 2 doses now, booster 6 months later, do they need another booster? So that's their 4th dose. That's where I'm not quite on board with that. I wouldn't discourage someone from doing it. I just don't think the science is quite there yet to say that it offers another level of protection.
So what do you say for the person that's been fully vaccinated, say it's Pfizer, I don't know for sure, but had 2 shots, and then they got COVID, and then now they're supposed to be getting a booster shot. Should they be going for that booster, or do they get their boost from having COVID?
So, I think that we need to start thinking in terms of immunity, not just vaccination. So clearly when you got COVID, you got some kind of natural immune response and you got antibodies and a T cell response. So that kind of counts as a vaccination. There are some studies that would suggest that the immune protection you got from that may not be as much as what you got from the vaccination. I don't know that science is clearly settled yet. There's also some early data suggesting that how sick you got with COVID may help determine how much of a protective effect you got. So the kid that my wife saw who had a positive COVID test for travel, who had no symptoms, that may not be a lot of immune protection from that Omicron infection, whereas the kid who got sick may have a higher level of an immune response. So I do think we need to count the infection as probably a vaccination, but I still would probably say 3 months after that, I would probably still think about getting a booster if you've not had it. Unless you just want to go in every month and do COVID antibody testing to see, okay, how long is this lasting me? What antibody levels did I get? Did I get a little or did I get a lot?
To sum all of this up, because there's still other questions that are asking about the medications and this and the vaccines, but to sum it all up, you're saying that you should get vaccinated regardless of what MS drug you're on?
Correct. And boosted.
And boosted. And if they need to get sufficient levels of antibodies up, that because they're on a B cell depleter, that they should go for the conversation with their physician about Evusheld.
Correct.
Okay.
Correct.
And that's a good way to sum up all that, right?
Absolutely.
Now, so in your own words, because I'm like down to maybe one question, but in your own words, what do you want people to know? I mean, it has been your own words all night. I understand that. But without me asking any questions, what do you want people to understand best about the current situation and their MS?
So we realize that the amount of information flying at people from 1,000 different, fire hoses, blasting in their face is overwhelming. There's information, there's misinformation. Politics have been introduced into this. I think, you could say, well, drug companies have a motivation to do certain things to make money. Take it all with a grain of salt. So step back and be a smart healthcare consumer. Vaccinations are safe for people with MS. The overwhelming weight of the evidence says that the benefit you get from being vaccinated and being boosted far outweighs the small risk that is out there. We don't know what's around the corner, so I think it's wise to be vaccinated and boosted. I think if you're on a therapy, especially a B-cell therapy, where you may not have gotten the full antibody response, it doesn't mean you didn't get some protection. You still got a T-cell response. But if we want to add another layer of protection for you, have that conversation with your healthcare team about getting the Evusheld if they have access to it. And we're all going to get through this. This is not going to be a forever thing. We're going to soon be able to do more normal things, I hope.
We have a lot more live programs again.
Yes, absolutely.
Yeah, exactly. All right, Doctor, I don't want to take any more time from you tonight. I know you have things to do, and I still have to eat dinner. So I'm going to say thank you for being online with us. And by the way, everybody, Dr. Thrower will be back online with us on March 5th. We're going to be doing a very, very special event with Dr. Thrower and Dr. Boster. All right, and it's going to be on March 5th from Columbus, Ohio. I will be there live with Dr. Boster, but Dr. Thrower will be doing it. He'll be coming in virtually, live streaming. All right, and we're going to be doing this about an attack on the immune system, and it's going to be like a skit. And I'm going to ask Dr. Thrower to be attacking the immune system, and I'm going to ask Dr. Boster to be defending the immune system. And we're going to bring out the entire thing, like from the beginning of when a person first starts having symptoms and whatnot, and having to go for MRIs and the different testing that they have to have. And we're just going to build through the whole thing of what it's like to get MS and what do you do about it. So, it's going to be interesting. It's going to be different. And we're going to have things on the screens for you to look at as they're talking about these different things. But one is going to be, and if Dr. Thrower wants to come dressed as a pirate, that's fine.
There you go. I'm a pirate pillaging the immune system.
That's right. And if Dr. Boster wants to come dressed in one of his many different outfits, who knows? But it would be pretty cool. And so that's what we'll be doing on March 5th. You all will be getting notices about this very, very shortly. So we hope to have you get registered, or if you're in Ohio, we hope you can come to the program. And Dr. Thrower, again, thank you very, very much for all of the work that you do for the MS community and for those around you.
Thank you very much. And everyone stay safe and healthy and have a good evening.
Great. Have a great night. Bye-bye.